Welcome, everyone, to this month's edition of the Digital Virtual Health Series. My name is Stephen McCollum. I'll be your host and MC today. Thank you all for joining us. And of course, thank you to all of our sponsors and partners who made this program possible. I want to give a big shout out to CareSignal and MedDecision for sponsoring this panel as well. You can check out about all the information about our sponsors and partners on the event website. We'll get started in just a couple minutes, but just a few quick housekeeping announcements while you're here. We have two ways for you to ask questions during the panel. You can ask your question live by clicking on the raise hand icon at the bottom of your screen. If you click on that, it'll alert me that you want to ask a question, and we'll be able to unmute your microphone and you can ask that question live. You can also ask questions in the chat box. And if your chat box isn't open, go ahead and click on the chat box and make sure that that's opened up. I'll be putting some fun stuff along the way, including links to all of our speaker bios in that chat box. And when you are chatting, make sure you chat with everyone, meaning you don't chat just to the panelists, that you choose to chat with the panelists and all attendees so that we can all see your responses. All right, well, with that, I'm going to go ahead and get our panelists introduced, and I'm just going to go left to right as I see folks on my screen. Up top, we've got Stacy Mays, who's the Senior Vice President and Chief Operating Officer of Preferred One. Welcome, Stacy. Next to Stacy, you obviously know who I am, so we're going to skip over to Blake. Blake Margraf is the Chief Executive Officer of CareSignal and joining us from my home state of Missouri. So welcome, Blake. Thanks for joining us today. Of course, our Editor-in-Chief, Mark Hagland, who is going to be our moderator today for today's discussion. Then we've got Dr. Lori Siebold. Dr. Siebold is the System Director of Case Management and Post-Acute Care and Physician Advising Services for Deaconess Health System in Evansville, Indiana. We've got Dr. Terry Steinberg. Dr. Steinberg is the Group Senior Vice President for Analytics and Population Health and the Chief Medical Officer at MedDecision. Welcome, Terry. And last but not least, joining us at the bright and early hour of 7 a.m. Pacific time, we've got Stacy Haruntas, who is the Chief Executive Officer of Sharp Reese Steely Physicians Group. So welcome, everyone. With that, I am going to turn off my screen and turn it over to Mark, and keep an eye on that chat because I'll be dropping some fun stuff in there in just a couple seconds. Welcome, everyone.
Thank you so much, Stephen, and welcome everyone. We're so excited to have you with us this morning. This is an incredible panel of incredible people, and I'm very excited actually. So I'm going to do a level set of the landscape around this topic, but first I'm going to give everyone 45 seconds each because we have a large panel and we have a lot to get to tell us about themselves. And I'm going to kind of this, as we like to say, we're kind of in Brady Bunch world, right? Like you see all the little boxes. I'm going to try to go in some logical order here, but I'm going to start to my left with Stacy Mays. Why don't you just tell us for about 45 seconds about your role in your organization, your connection to the topic. Thank you.
Good morning. Thanks, Mark. I'm Stacy Mays. I'm the Chief Operating Officer, Senior Vice President at Preferred One. We are a provider-owned health plan based in Minneapolis. We've been around for about 36 years, so a very long run in the provider-owned space. My responsibilities at Preferred One include all of our clinical operations, all of our administrative operations, so the things you usually think about: claims, customer service, enrollment, eligibility, those things, IT, network, and most recently legal and our regulatory areas. So very broad portfolio. And I have the opportunity to do a lot of integration among those departments and ensure that we're delivering integrated services to all of our members.
Thank you, Stacy. Dr. Terry Steinberg, why don't you share about yourself with us?
Thank you. Well, good morning, everyone. I work for MedDecision. MedDecision is well known as the care management company that has the aerial care management and utilization management suite of applications. And I am really excited. I'm new to MedDecision, about 3 months, And I'm really excited to be helping MedDecision transition to the platform services arena. We believe that everything that can be virtual in the future will be virtual, and that participating in the healthcare ecosystem is really important. And so I am working on the advanced analytics platform, the interoperability capabilities, the data capabilities, the remote data acquisition and home capabilities, and really moving the needle from traditional care management into an application that touches all aspects of the person's life and can enable all of the healthcare applications in the ecosystem to work together. Very exciting where Ariel's going. I spent about 10 years in the software world and have been in healthcare IT for a total of about 30 years. And most of my time, I'm a geriatrician by training, most of my time has been spent on the provider side. I was the Chief Health Information Officer at Christiana Care Health System, and really worked for the last 10 years on data analytics and population health. So I'm really excited to be joining you today with that really very broad background in population health and data analytics.
Great.
Thank you for inviting me.
Thank you so much. Wonderful. Stacy Hrontas, who wins the award for the most beautiful background.
Well, welcome to San Diego, a little bit of it, right? Sharp Staley, I've been at Sharp Healthcare for 27 years, most recently in my role for 9 years. And Sharp Staley is the first multi-specialty medical group in San Diego 98 years ago, where two physicians, a GP and a specialist, believed that integrated care was best for San Diegans, and we've evolved since then. I think a couple points about our organization that's important. We're nestled within a bigger healthcare system that does have a not-for-profit health plan, as well as 4 acute care hospitals, 2 specialty hospitals. But we took our first capitated contracts 35 years ago, and today about 70% of our revenue is capitated and prepaid, and about 50% of our visits.
Great.
A little bit in San Diego, and we're bordered by Mexico, the Pacific Ocean, the desert, and Camp Pendleton, which really stops LA Orange County coming down to San Diego.
Exactly. It's amazing. People have described the San Diego area as an island, and until you visit, it's hard to understand how that could work. Thank you, Stacy. One tiny favor, can you raise your volume in any way, just slightly? That would be great,
okay,
if that's possible. Thank you. Dr. Lori Siebold, tell us about yourself, please.
Oh, good morning. Thank you so much for letting me join. I'm an emergency physician by training. I'm located here in the Midwest in Evansville, Indiana. And just to let people know where Evansville is, because we're hardly the mecca that San Diego and some other sites are. We're in a reasonably rural area. We are dead center between Nashville and Indianapolis. And then east to west, it is St. Louis to Louisville. So we capture a very large area between those large cities and tend to serve a relatively rural population. We are an independent 11 hospital system. We have 3 acute care facilities, 2 acute care access hospitals, and then 6 specialty hospitals that we oversee. I'm the system director for our case management program, but then I'm a little bit of a jack of all trades. I started our internal physician advising program a few years ago, then became the director over case management, physician advising, and post-acute care services. I also oversee all of our population health areas. We have several Medicare Advantage programs where we participate in their value-based purchasing, as well as our own ACO, Deaconess Care Integration. We've been nationally ranked for the last several years with quality and shared savings for the last several years through the ACO. And most recently, I have been tapped to help start our own provider-owned Medicare Advantage plan that went live January 1st. So much like the other panelists, kind of a jack of all trades and loving all of it, learning stuff every day.
And other than that, you're sitting on the veranda drinking mint juleps, right?
Exactly.
That's a pretty full portfolio, I have to say.
Yeah, keeps me busy.
Wonderful. Thank you, Dr. Siebold. Blake Margraf, also wonderful background that makes me want to dance.
That's right. That's the intended effect, Mark. Appreciate it. Privileged to join you and join everyone today. I started the company CareSignal with my co-founding team in 2015. We are healthcare consultants, physicians, engineers, technologists, and we all wanted to bring more evidence to the different remote monitoring and engagement solutions that existed. So for the first couple of years, we focused just on that, thousands of patients in studies and trials, 12 peer-reviewed publications. And what that led us to is essentially deviceless remote patient monitoring. We have the privilege of working with care management teams across the country, serving predominantly Medicare Advantage and other polychronic or medically underserved populations, almost all of them at some level of financial risk. And instead of using expensive devices, we're able to lower the cost, but also expand the monitoring to conditions that otherwise would be inaccessible. Think behavioral health, social determinants of health. Since we're all just scientists, researchers at our core, we're continuing to do as much research as possible to prove what we can.
Wonderful. Thank you, Blake. What a wonderful panel. We could just sit and talk about ourselves, but we do have a topic. I would like to just spend literally about a minute or so doing a level set. I'm very excited about this topic. As we all know, care management has been in a state of continuous evolution for years now in healthcare, and we actually need to evolve it forward even further. One of the key elements here that we all know is a combination of desired outcomes and cost control. I just wrote a blog the day before yesterday about the latest MedPAC report, the Medicare Payment Commission and Advisory Commission, and it's actually quite shocking. I think everyone should read it. The Medicare Trust Fund is about to run out of money in a couple of years, which is really, they had estimated 2026 and now they're saying 2024. Well, guess what? We're in 2021. That's literally 3 years from now, they're going to run out of money. And the Medicare actuaries have also been predicting for a couple of years now that we are about to go to a $6 trillion annual overall healthcare expenditures in the US from the current about 3.6 trillion. So within a few years, our healthcare system will cost 70% more. And as we all know, we can barely sustain what we have. So one of the key things that MedPAC noted in the report, which I think really speaks to what we're going to talk about in just a second here, is the idea that we can no longer maintain the core fee-for-service based healthcare system that we have right now. We have to shift it forward, and every single one of you is involved in that. So you're already at the tip of the spear. So let's talk about that. And also, I wanted to add another thing that I want us all to talk about, which is the impact of the COVID-19 pandemic. We learned a lot, I think, and I'm going to ask every single person on this panel to share what they learned. But I think I'm going to start with Stacey Hrontis, if I may, because you said something in our prep call that I thought was just so great about your positioning. Sharpry Staley has spent 35 years now in value-based payment contracts. And so what were the first few months of the pandemic like for you in contrast to most physician groups around the country?
Well, I think what really helped us was our dabbling in telemedicine at the beginning. So all of our primary care physicians were trained in our video platform. And I remember over the weekend when we got the public health notice in San Diego that schools were closed and we're shutting down clinics. We got all of our physicians and their dyad partners in a room. That's when we could still get together in a room without masks.
Right.
Little did we know. And we had a plan to convert all of our visits that couldn't wait 2 months to video visits. And we really did that over the weekend. And so Monday morning we were up and running. And our specialty physicians did the same thing, but it was a little bit more daunting for them. The telemedicine platform we used, because then everybody in the whole nation was using it, kind of took it to its knees a little bit. But we did audio or video visits with everyone. So I think that was one of the most quick pivot that we had done. We closed shuttered offices because we were low on certain PPE, and we really consolidated that site. So we were able to really mobilize very quickly with not a lot of facts and information at that point in time.
But the great thing, as you mentioned to us, is that because you're 70% capitated, unlike some medical groups, your revenues didn't crash through the floor.
Correct. That was a godsend in that we didn't have to worry about that fee-for-service volume, and really taking care of our patients through video or Follow My Health, our patient portal, really helped us out a lot. But we didn't have to worry about getting paid on a fee-for-service basis. And
Right.
that really helped us in the first part of the pandemic. Absolutely.
Yeah. And I think, thank you very much, Stacey. And I think one of the things that I will tell you that APG, NACOS, AMGA, and other associations have really pointed out that the pandemic has helped people realize that value-based contracting, which includes care management at its core, is going to be a core element in moving us forward. Let me, everyone can jump in, but let me go to Stacey Mays for a moment. Your perspectives on what we've just said.
So, and I want to thank Stacey for her comments because, you know, sort of beating the drum for value-based compensation programs and capitation specifically has been a very difficult message to carry in markets where that's not the case.
Yeah.
And so being in Minnesota and in a market that was originally very capitated. So 25 years ago, this was a capitated market. It moved completely 180 degrees in the other direction. And it's now a very fee-for-service driven market. And using the opportunity to chat with providers about the fact that their very devastating financial impact of the pandemic could have been avoided, at least somewhat, by being open to value-based compensation and to capitation specifically. And so, you know, I think it's been very eye-opening. I think, though, one of the things that we've learned as a health plan, first about our teams, similar to Stacey's, they are very resilient. They are very flexible. They are very willing to do whatever they have to do to deliver services to our members. And, you know, we had a 36-year history of working in our office, and that changed overnight. And so, you know, our staff was doing things differently. Our care managers specifically really were changing the way they worked as well. You know, we learned that we really have to meet our members where they are. And we have to be very mindful, even so we are 100% commercial. So we have no government program business except for a little bit of ACA. And even in our commercial populations, we have to be very, very mindful of social determinants of health. We have to really understand, and, you know, in Minneapolis, we've had the violence associated with the very unfortunate incidents last summer. And, you know, lots of folks who lost their pharmacy, lost access to their provider, lost their homes or access to their homes for a period of time. And we really had to meet those folks where they were. And it was kind of like, you know, people don't fit into programs necessarily. We have to provide the support that they need, you know, in the way that they need it.
Exactly. Thank you, Stacey. And let's just ask everyone else if anyone else has perspectives on what's been learned during the pandemic, and then we'll move to the next topic. Who else would like to join?
You know, I would like to bring up our post-acute care network, something like Stacey and her San Diego team. We leverage telehealth and essentially immediately. We were fortunate that we had that platform in place before, and we were able to pivot very quickly. But a second thing that I think we really learned as a health system was the importance of our post-acute care network. We have a set of dedicated nurse practitioners that care for our value-based purchasing patients in all of the different facilities. Deaconess, my health system, does not own post-acute care facilities. So these are relationships that we were able to build over time. Again, we're fairly rural, so we have about a 3,000 square mile footprint of post-acute care facilities that we send patients to regularly. And we leveraged a telehealth platform to connect all of those facilities, and then allowed through telehealth through that platform that our nurse practitioners were able to treat in place, and we were able to keep our patients in their post-acute care facilities and protect them from transferring to the acute care hospitals in the early months before we really knew how to best handle this. So I think it's both ends of that spectrum.
If I can just share my perspective, which is a bit unusual because I have been on both sides of the world as a user of the software that I also now develop. And I have to say that during the pandemic, what proved to be critical when I was still at Christiana Care as a user of MedDecision software was the outreach to consumers, the idea that you could actually monitor people in their homes. You understood you could use outreach text messages and emails and video visits to actually understand of your COVID population that was being managed, who was getting into trouble. And then we were fortunate at Christiana Care to land an FCC grant that allowed support for outreach teams who would go into the home instead of saying to the patient, you have COVID and it looks like you're getting into trouble, or we're not sure what your status is. Instead of saying, now go to the emergency department, we could dispatch teams of individuals using telehealth tools, literally suitcases of diagnostic devices that would connect the person in their home to the provider behind the screen, and really take telehealth from a scheduled static activity to something that was more real time, similar to what Lori was describing. And so it's been very it's been a wonderful experience to actually see how things work in the field, and then to be able to think about how you build those to be a 360-degree virtual health engagement, because I think we're all pretty clear on the fact that if you can do things in the home going forward, you should be doing things in the home. Not everything can be done in the home, but everything that can be done should be. Which is really a guiding principle that we've taken from COVID and now moved into our future goals and strategies.
Thank you so much. Blake, I know you wanted to, that great comment. I know you wanted to say something also, Blake.
I just couldn't agree more with Dr. Steinberg and Dr. Siebold. I think that relationship, bringing that same quality of relationship to a necessarily more virtualized relationship and process is crucial. And our key learning has been first, make sure that teams are allocating the appropriate license, right? Everybody talks about just top of license. I think that almost minimizes the importance of seeing exactly how far you can go with teams that maybe have a centralized individual who is able to rapidly and scalably triage patient demand. And then long-term, accessibility trumps everything else. The greatest technology on paper will crumple when it faces technology that anyone can use at any time for a really long time. Dr. Steinberg, it's exactly what you shared, right? Sometimes the best technology feels like no technology at all because it's so ubiquitous and accessible. So could not agree more.
Thank you very much, Blake. So I want to talk now about what it is we've learned about where the gaps are in care management across the health system. And I know that's a very general question, and different healthcare markets are more advanced than others. But what I'm going to do, I'm I'm going to do a Stacy now. I'm going to ask Stacy Mays from the plan side where you see gaps in terms of overall care management that providers are creating. And then I know Stacy Hruntis would like to talk a little bit about the 35 years in which her organizations, physicians, and administrative leaders have created a culture in which care management is at the core. So let's go to Stacy Mays first from the health plan standpoint.
So I think there are several gaps, and I alluded to a couple of them in my previous comment. I think there are still many gaps in the social determinant space. I think we really need to pay attention to the things that impact our members' healthcare, that may not be directly related to their healthcare, but certainly influence their access to care and their outcomes. There are still tremendous gaps in mental health, in both the integration of mental health services into physical health, as well as access to mental health services generally. And I think, I look at things from the perspective of what can we do as a health plan to support our provider community in order to incorporate those services. So I think there are gaps there. I also think we've discovered there's some pretty dramatic gaps in public health information that could and should shape some of the programs that we develop either in the provider community or within a health plan or both. We've had some pretty interesting missteps in even the original direction from CMS for providers not to build the type of vaccine that a member received because we weren't going to be paying for that. But there's really no sort of central repository of that information. And we really don't have as detailed information as we'd like, I think, in, from a national level on vaccine and what percentage of the population is being vaccinated, because when we look into the data, different states are collecting things in different ways and the numbers don't match up. Yeah. So I think there are data gaps for sure. Yeah. So, those are just a few that come to mind from the plan perspective.
Great. Thank you, Stacey. And in just a moment, we'll be plunging into the data maelstrom. So thanks for presaging that. Stacey Hruntis, one of the great things that you and your colleagues have done at Sharp Priest Daily is created a whole culture in which care management is really, it's what you do. Tell us a little bit about that.
Thank you, because it's something that we do. I don't even think that it's anything different that other people aren't doing, but 35 years ago, really changing the compensation model really stimulated people to think in a different way. And the first thing that engaged our physicians in a significant way, down to the frontline physicians, to the physician leadership. And we really paired our physicians with an administrative dyad leader, which many have done in the nation. But we've really, in the last couple of years as well, really looked at the different levels of management, frontline, site leads versus regional leads, physicians, and different specialties and service lines. And we really have used our data because we pay claims. We're kind of like a mini health plan for our about 186,000 capitated lives. And so we have our data from our electronic health records, which is fully integrated on the ambulatory side, as well as all of our claims data that we pay for outside people. So we are able to run data, and that really ties in. So it's knowledge, giving our physicians and their dyad partner knowledge to make decisions, to do experiments, to really improve things for our patients. And we really focus on gaps in care, our preventative measures. Our physicians and their comp model are incentivized to do more. They're incentivized to do what's right for our patient. And I remember one of our prior physician leaders talked about when they took the OB department and really changed their compensation model, how it changed behavior for the better for our patients.
Wonderful. Perfect. Thank you. Dr. Laurie Siebold, tell us a little bit. You've been doing some pioneering work in care management that has really had an impact in terms of reducing readmissions. Tell us a little bit about that, if you would, please.
Sure. So as I alluded earlier, we developed several years ago when we first entered the value-based contract world, we developed 2 post-acute care networks for our region. We have a network where we have embedded nurse practitioners, and then we have a network where we utilize a call service. So Deaconess was fortunate to have some really visionary leaders several years ago develop what we call our nursing home triage center. It's a 24-hour bank of phone nurses, essentially. So a number of these facilities in our area that, again, we do not own, we do not have any financial relationships with, we simply have good partnerships with, purchase our nursing home triage services so that anytime any of their patients have any issues, they're able to call that phone line, and we are able to send it through several different protocols and treat in place. With our actual partnered facilities, we're able to leverage our telehealth platform. We use an Olio platform out of Indianapolis, and we're able to set up those acute care visits with the patient real time using either remote patient monitoring tools or nurse assisted tools in the nursing home where our nurse practitioners, or if necessary, escalations to our geriatricians, our primary care physicians, and we can treat those patients in place. We only transfer to our health system emergency departments if we feel that the patient would benefit from that level of care. But we've had significant improvements in quality, in patient satisfaction, and significant cost containment over the last few years utilizing either the nursing home triage call center or the embedded nurse practitioner programs. So I really feel like I've been very lucky to inherit these systems and been able to grow them. We've had nursing home days significantly decreased. When we first instituted the Olio IT platform across all of our nursing home networks, we were averaging more than 23 to 24 days per patient per encounter, and we're down to an average day count of only 17 now. So as you can imagine, that's significant benefit to the patients and to their families. We're able to get them home much more rapidly, and we're also able to kind of be a little bit of a big brother, or there's certainly some Hathorn effect to us being able to look at these patients every day. And there's a great cost savings because instead of having embedded nurse case managers I have 164 facilities that we use. And instead of having, over 100 nurses covering these 3,000 square miles in all of these facilities, I have about 15 nurses that use the Olio platform and remotely look in on all of these patients every day.
That's wonderful. Thank you. What a huge kudos to you for your record of success. And not only is it wonderful in itself, but I love that your organization is in an area you have almost no capitation. So it's not an advanced payment market. And to me, that makes your case study even more potent, right? Because it shows that you can do this anywhere if you know what you're doing. So
we have several upside downside value-based contracts, but yes, we've been very fortunate to kind of get ahead of the curve.
Yeah, great. Thank you so much. So let's plunge headlong into the data world. And every single person on this panel will have insights to share. So I'll call on all of you. I guess I'll start with a jump ball question. What is the latest, what is the leading edge in terms of leveraging data for care management right now? What's at what's the tip of the spear, and who would like to begin?
Well, so if it's okay, I'll start. I've been, playing with care management and data to drive care management for almost 10 years and doing research on this. And I guess you can't really talk about data in care management without describing how care management has changed. So from the beginning when I started, and I guess the way to best describe this, and it's something that's obvious to everyone, both on the panel and participating, is that, care management used to be an activity that was performed by the payers, sort of forced on people, very often without much known about that individual. So it was payer driven. Hello, I'm your payer. I'm doing care management for the benefit of the payer, not necessarily for you. And this is something you have to go through. And that has completely changed to being something that is now being done as a partnership between payer and provider. It's often focused on the provider. It's often driven by the provider, or at least in partnership. Hello, I'm from Dr. So-and-so's office, and we are here for your benefit. And most often it's with an intimate knowledge of what's going on with that person. And in many cases, it has this outreach activity provides the person with information that the person didn't have. So really, the whole notion of care management has changed, but it has also become commoditized to some degree. And the real asset are the data that surrounds care management. And so care management has also changed from the notion of a static relationship between care manager and member. This care manager now has 2,000 members and has a specific list of work to do. From that to care managers have a more dynamic list that is data driven. If you're on the list, it's not because you were assigned, it's because you've had a data event that has put you on that list. And the actual number of people managed is much larger, to the point where very often all of a population is being managed all of the time, and people are brought to the attention of another human because they've had a data event. And so data becomes important in terms of the ability or bringing people to the attention of healthcare as a result of a data event, but also populations are segmented, which is of course the hallmark of population health management, as a result of data events. And this requires advanced data and analytic systems that are integrated with all of the other digital systems in the healthcare ecosystem. So data is king, or data are king, and depending on how you want to look at it, in terms of enabling the foundational healthcare technology systems to work. And human beings are brought within the digital systems on the basis of data events. And we all need to build systems and use systems in the future that are dynamic enough to have data, to be able to see data at a national level, bring those data within our own systems so that we can provide proper care based on the data.
Absolutely. Thank you so much. And I'm going to go to both Stacy's again, because one of the things that I know both of you are involved in is marrying clinical and claims data and plans and providers collaborating around data. So I'd love for both Stacy Mays and Stacy Horrentis to share what that's been like, because that to me is also leading edge, and it fits in with what Dr. Steinberg just said, which is we're no longer, we're really using data to help animate care management now.
Yeah. So as a customer of Dr. Steinberg's system, we are in the process of implementing MedDecision in our organization. And so beginning to use some of the early capabilities of that system to understand the behaviors of our population and to really share information with our providers. One of the areas, though, that I do want to highlight is just the importance of integrating pharmacy data with the medical management and claims data that we have available. We are very focused on using our pharmacy data as an early warning system knowing what is potentially going on with our members and building some predictive analytics around that data. It's become very important. We're also going down a path of both stratifying our physician care delivery system based on cost and outcomes, and providing our practitioners, our providers, with data to show them where they are relative to others in the network, and to really help them adopt best-in-class practice around different kinds of care delivery, and really letting the physicians drive that process. I mean, it's not up to us as a payer to tell anybody how to practice. All we can do is provide the data, provide the insight, and then let our providers sort of react to the information and change behavior based on that performance. We are modifying our payment methodologies for providers, still staying in a mostly fee-for-service environment because that's what the market is demanding, but changing the compensation to support that. And prior to coming to Preferred One, I was at UNC. So on the care delivery side, helping providers react to the kinds of data that we're providing and building tools and some systems to move that organization from fee-for-service to value. So bringing some of that insight also to my role on the payer side, and just having our clinical teams partner, really looking at the whole patient, you know, all of those good things that we've been talking about for a while that I think now are actually happening.
Yeah, exactly. Well said, Stacy. Stacy Hrontas.
So it's, I think we're really lucky in that, for 35 years, the health plans have delegated claims payment as well as utilization management to the providers, to the medical group. And we have all of our electronic health information. We have all of our paid claims information outside of our system. Our hospitals are capitated for the majority of our HMO members. So we feed all of that data into a data warehouse, and we're migrating that to data lakes and all those things that all of my IT people tell me about. And then we get the pharmacy data from our health plans for those that we are partnering with that are willing to give that. We don't have our mental health information because it's the health plans are at risk for mental health. And so that's a gap, I would say, on the commercial side. For senior, we do have our mental health information because we're actually paying claims and subcapitating our provider. But if you think about our data, so our physicians at all levels, so frontline physicians have their PAR report, which shows how they perform in the patient experience information. So we have patient experience, Press-Ganey information profile for them, their gaps in care. So for the screenings mechanisms, they see how they perform individually, as well as in our diabetes perfect care, high blood pressure, and a whole host of information. And then the site leads are able to get that information through Tableau to see how they are performing and can really coach and mentor that dyad team down to the frontline level. And then the regional medical directors do the same in primary care. And then we have our chief medical officer that looks at Sharper's Daily overall and how we're performing. So we're able to use the data. And, we have dabbled, I would say, in a couple commercial PPO ACOs. And it's so awkward for us because we don't have the data. The data is always delayed. We get data files, they're not complete. The health plans are saying, why aren't you looking at these patients? Well, that happened months ago. And so it's, something that's very awkward for us because we're trying to apply our HMO tools that we've used for 35 years to a population that we don't have great information. So exactly. Data is knowledge. And physicians, I love working with physicians because they're so bright and so really want to do the right thing for the patient. And you pair that with administrative party that can really look at, and clinical, and really look at how you can do things differently from a patient perspective, which is so valuable. Yeah. We also have diabetes case managers that are embedded in primary care that work with, they have their physician and partners in terms of specific patients. Obviously, we have a diabetic population, especially in South Bay and San Diego. And then we have our case managers that are centralized that also use our data analytics to identify those patients in different disease categories that we want to manage differently, deploy remote monitoring, things of that nature. So that's kind of a little bit snippet of how we use our data.
That's pretty amazing, I have to say. Huge kudos to you. You've really embedded the leveraging of data into every single thing that you do, essentially, right? I mean, it's a part of what you do. So congratulations.
Mark, would it be okay with you if I just jumped in with one more comment?
Sure. And then I want to go to Blake and to Dr. Lori Siebold, but go ahead.
I'll make it really quick. It's really important to bring the data, as exactly what Stacy said, as close to the operations as possible. And one of the things that I'm really privileged to be working on now is a platform service that basically puts a call out to national data sources and simply pulls it in and then generates rules, alerts, reminders, care management triggers, you name it. So that's really essential, is if you don't have the data, use a system that can go get the data and bring it in and then tell the person what they need to do. Retrospective data is really important, but real-time data that is actionable, that can generate alerts and reminders, but especially alerts and triggers is really important.
Yeah, that's a great point. Thank you. Thank you. Blake, I know you wanted to share also.
Sure. No, I think Dr. Steinberg's point is a great jumping off point as well. I think there's a new mental model that the folks on this call are evidence of, that are introducing to care management, which is, it's not just the data that exists in the world today. Sometimes you need to seek out rare data that don't yet exist. And the other attribute that, as we call it, rare data tend to have, is those data generally have a short period of actionability, wherein they can be applied to create value, initially clinical and then financial value, particularly in the context of care management. I'll share just to put some numbers to the theory there. One of our initiatives within Care Signal, where we need to keep patients engaged for the longest duration possible to create value for our partners and then for ourselves, right? So interests are aligned. One of the challenges we have is re-engaging patients after they've fallen off. 2-3 years go by, maybe someone changes homes, geographies, plans, that patient falls off. We only have about a 5 or 10% success rate in asking that patient to come back onto the system, which is really a bummer, because that's a lot of clinical value left on the table. However, if we're able to predict which patients will fall off and reach out just a week or two before they fall off, if this were an audience, I'd say, anybody have a guess? 57% success rate in preventing someone from falling off, which is really the promise. Now, of course, the challenge is, how do you do that in a robust, sustainable way for challenging populations? And that's exactly where rare data come into their own. Mark.
Thank you. Yeah, exactly. Dr. Siebold, I'm sure you have thoughts on this.
Sure. I couldn't agree with everybody on the panel more. Population health is the wave of the future. I think it's our nation's direction for healthcare, but it's absolutely based on data. And without the data, you cannot care for the patients and you cannot manage the patients. So everything from having live actionable data. One of the first things I realized when I moved into pop health a few years ago was, as Stacy alluded to, the data was old data. It was CMS data, claims-based data that was 3, 6, 9 months out of date. And it's so hard to fix a problem when it occurred almost a year ago. And how do you manage a population that far away? So any venture, anything that I would tell anybody in the audience to seek out people like Dr. Steinberg, like Blake, that can help you receive live data, actionable data that you can put into the hands of your physician. I think Deaconess has been really, really successful because we're very transparent with our physicians. We've had a dyad model like you speak of with an administrative physician leader in all of our major areas for years now. And we really pride ourselves on getting as much data as we can to those leaders as transparently as we can. We don't always have the answer. We don't always have the right data, but we'll give you what we have. And then we're going to use your mind to help us decide what to approach in the future. And again, I don't shy away from third-party vendors because there are some really fabulous opportunities out there, and I would encourage everybody to investigate what's in the region as well as what's nationally available. For instance, just in the first quarter of 2021, I can tell you that despite having an enormous COVID population hit us in that November to February range, I was still able to keep my nursing home days at that 16 to 17 day level. And I really pride that on the data, on the fact that we were able to check in on those patients every day. We were able to triage the ones that needed help immediately. We were able to leverage all of the different video platforms and the remote patient monitoring platforms that
Right.
We've contracted with. And I think it provided good healthcare, and I think our patients benefited from it. And as a physician, that's really what it comes down to. I think if you do what's right for the patient, it's going to be what's right for the health system as well.
Absolutely. And per that, I wanted to ask Blake to say something about the fact that, first of all, the fact that you and your colleagues were able to address urgent and emergent situations, Dr. Siebold. That's terrific with the real-time data. Blake, you had made a comment to me when we connected before this panel about catching the rising risk patients and plan members. And that's going to be a key part of care management too, because most, if you talk to any physician in practice, they can rattle off the names of the 15 patients they see all the time because they see them all the time, right? Like, yeah, I just saw Mrs. Smith last week and she has blah, blah, blah. But we need to also be catching the rising risk patients and plan members. Just what are your thoughts on that?
You nailed it, Mark. I mean, Dr. Siebold hit the nail on the head as well, right? It's if you do what's right for patients, the rest will follow, especially as we move more and more into value. A paper came out right at the beginning of last calendar year showing that when provider groups that were under risk focused just on containing costs and providing heavy support infrastructure for the highest utilizers, for the super utilizers and very high risk folks, they weren't able to bend the cost curve beyond neutral if they got it to neutral, whereas those that instead focused on rising risk fundamentally shifted the cost trajectory of those patients, and that led to savings long term. And this is, I mean, I think this is perhaps the best kind of application of just simple calculus, right? You look at the curve, and when you bend that normal distribution of cost, the curve can fall dramatically, but the narrow band of super high risk folks is still so narrow that it just becomes intuitive that you have to go down the cost curve if you want to create sustainable.
Absolutely. Yeah, there're just a lot more people in the rising risk. So we're running out of time. So here's what I'm going to do. I'm going to ask a question of the panel that has been asked by one of our attendees, and then we will literally have 5 minutes for closing remarks. So I'm going to ask each panelist to share a piece of advice or a prediction, and they get 1 minute. But let me quickly ask the question. I'm sorry, that's really hard. I know, right? Please summarize the fate of the universe in 30 seconds. But the question from Harrison McDonald is, what kind of data analysis methods do you use, e.g. statistical? What tools do you use, Tableau, Python, etc.? We don't really have time for everyone to jump in, but maybe, I don't know. Let me go quickly to Dr. Laurie Siebold and Stacy Hrontis as the providers. Brief scan of what you use.
I know that our health system uses Tableau quite a bit, but then as I alluded to earlier, I utilize 2 different outside vendors to do a heavy analytics for us. The internal analytics department at my facility is really growing by leaps and bounds, but we're just not there yet. So in addition to Tableau and all of our Epic tools, then I do utilize the Olio services as well as another very large vendor to do my heavy analytics. So I'm probably not the best person to answer that. I'm sorry.
It's okay. Stacy Hrontis?
We use Tableau as well. We use internal data warehouse where we funneled all this information, but we're converting to, and for our pay for performance through Integrated Healthcare Association, we have to provide information a certain manner. So we're converting to an outside vendor whose name I do not recall. I'm not as close on that project, but we need that more AI aspect of it, as well as data in a more, less intensive resource based on internal FTE.
Great, thanks so much. Okay, now, got your speed caps on, everyone? We literally have 5 minutes. So I'm going to ask each panelist to do 55 seconds and give us either a piece of advice to leave for our audience or a prediction for what will happen in this area in the next couple of years. And I'm going to literally go around the circle as my Brady box view looks. Stacey Mays, I'll start with you.
Oh, of course. Thanks, Mark. I think that as we look out over the next few years, I think we all have to keep a very open mind, be open to new partnerships, be open to new sources of data, be open to making sure that we're meeting our members where they are and being problem solvers. I think the sort of old paradigms are finally not going to hold, and that we're going to see a lot of evolution in things like precision medicine and other sorts of both individual and population-based approaches. And I think all of us just need to keep an open mind and be willing to accept new things.
Wonderful. As a good friend of mine would say, I violently agree. So Dr. Lori Siebold, next.
So I guess I would give people, instead of a prediction, my advice. And that is, I'm a hospital-based physician manager. And I think the most important thing is for those of us in the hospital to not forget the outpatient world. As value-based care and capitation become more and more prevalent throughout the United States, the large spend is really in our outpatient worlds. And as telehealth evolves, as remote patient monitoring evolves, I would really encourage you to go out and look for those new relationships. As I described, the 164 different facilities that I discharge people to, 90% of our discharges go to those 164 in addition to home. And those are some fierce competitors, yet through honest negotiation and compromise have been able to build a rapport and build a network and get them to agree to a single IT platform that they would communicate with me on. And it's been value. I mean, the value I've achieved both financially and in quality is just, I can't speak highly enough of it. They send me their quality metrics each month. I'm able to give that to patients and let patients make smart decisions about where they want their loved ones to go or where they want to go themselves. So I would encourage that out of the box thinking. Look at your community, look at your available options, and really talk to those home health, to those skilled facilities, to those hospice facilities, and make those partnerships.
Thank you so much. I also violently agree. So now we're kind of down to about 48 seconds each, but please go ahead, Dr. Terry Steinberg.
Well, so data are king, or maybe the entire royal family. As you go forward, think about how you can share data without having to have hundreds, if not thousands, of point-to-point interfaces. So you can spend all your time building pipes. Don't do that. Find a strategy and user strategy that lets somebody else build those pipes and connectivity. And then my other prediction is that healthcare will become frictionless. Just like you don't make an appointment to go to the bank, you won't make an appointment to go to the doctor. The digital tools will help people integrate healthcare into their everyday lives. And again, look for systems that allow that to happen.
Thank you so much. Perfect. Stacey Hrontes.
I just want to echo what everyone's talking about, but there are a couple key places I'd like to emphasize. One is engage physicians in the care team. That's really where the magic happens. And also engage the patient, because the patient needs to become, really center and driving it and more engaged and responsible for their health. And so if you can enlight that in different ways, I think that's really where you need to focus in the future. Also, we have, if you think about the health burden, we have obesity in this nation that we all need to focus on, because that really leads to a lot of bad outcomes for people. Just look at COVID. So how do we as a community, school districts, public health organizations, healthcare providers, everyone focus on how we get our people healthy?
Thank you so much. Blake.
Yep. Our most innovative partners, I'll borrow from their expertise. Our most innovative partners are spreading risk, not just taking risk, but moving that risk downstream to their own technology partners and providers. They're also investing heavily in remote patient monitoring that tackles social determinants of health and behavioral health, full spectrum, not just chronic conditions. And I like to follow their example. Thanks, Mark.
Thank you. And I'll just say one last comment. We've got the burning platform in US healthcare. And in my recent interviews with policy leaders and advocacy leaders who work up on the Hill for their associations, they're all saying this is all headed towards eventually capitation, but towards APMs, towards alternative payment models. Everybody needs to look at that, and care management fits perfectly into that, because the only other alternative is massive, massive, massive Medicare and Medicaid payment cuts from the federal government, and everyone knows that that's unpalatable. So let's move ahead. Our panelists have been absolutely fabulous. Thank you all. You've been terrific, really. Thank you. And Stephen has magically reappeared.
I'm back. Yeah, thank you all. What a wonderful way to start off this day. And Stacy, again, thank you for getting up so early out there on the West Coast. Really appreciate it. All right, folks. So that wraps up this session. Coming up at 12 and at 2 Eastern, we have two very different discussions on patient engagement. Our first discussion is our panel discussion, where we'll be discussing patient engagement trends and how to create the digital front door. And our second discussion on patient engagement actually features two tech leaders, and they're going to be talking about how they worked with the various stakeholders in their organizations to actually power their patient engagement solutions with the right technology stack. And of course, we're wrapping up the day at 3 p.m. with our fantastic panel on social determinants of health. Much like this session, we have a great variety of speakers on that panel, including the former Deputy National Coordinator for Health Information Technology with the U.S. Department of Health and Human Services. So we're very happy to have him here with us today for that session. As a reminder, the sessions will be available on demand. And thank you again to our sponsors, CareSignal and MedDecision. Of course, thank you to all of our panelists. And panelists, when I hit the end button, we're all going to hang up and along with everybody else. So thank you, panelists, so much. I'll follow up with an email
Thank
to
you
all. And of course, all the attendees, thank you for joining us. And we'll see you right back here at 12 Eastern. See y'all soon. Bye-bye.
Take care.